We presented some data today looking at two patient populations, metastatic colorectal cancer and metastatic pancreatic cancer, and using radiation in combination with immunotherapy, two particular immunotherapy drugs, ipilimumab, which is a CTLA-4 antagonist, as well as nivolumab, which is PD-1 therapy. And we use that in combination, given some early preclinical data suggesting that the use of radiation with these two immunotherapy drugs might stimulate an immune response. Typically, these are cancers where the immunotherapy doesn't work historically, except for rare subgroups of patients, particularly the MSI patients. And so what we wanted to do was see if this approach could actually harness an immune response in these otherwise immunogenically cold tumors. It was a single institution study just done at the Massachusetts General with 40 patients in colorectal cancer and 25 patients in pancreatic cancer. And what we showed was that indeed in a select number of patients, 15 to 20% in the both combined cohorts of patients were able to receive the radiation, we were able to stimulate an immune response. So for us, that was quite exciting, as historically immunotherapy doesn't work in these patients, and in combination with radiation, we might have a path forward in terms of a subset of patients that might actually benefit. So we presented the clinical data today showing the efficacy data, but all of the correlative data in terms of biopsies as well as liquid biopsies and other blood-based biomarker work is still ongoing, and we'll present that at a further date. So we think that part of what radiation does is stimulate a neoantigen response from the cell death that is happening, and so when you have neoantigen presentation, that may be able to stimulate an immune response, and in combination with CTLA-4, which impacts T regulatory cells, as well as PD-1, which enhances the activity of the CD8 cells, that you might create the right immune environment with the proper neoantigens as well as the proper immune cells to actually elicit a response. Yeah, that's a great question. So, we chose right now a non-ablative dose of radiotherapy. So it was just 8 grade times 3. So that is not a very big dose of radiotherapy. And we did it only one time, and we did it to a lesion of the radiation and oncologist choice. So it will be hard to know what the exact timing as well as the dosage of radiation is, and we'll be exploring those in subsequent studies. I think the first imminent study that's to come is moving the radiation on the same schedule and same dosing, but moving it up to the earlier in treatment, so at the start of therapy with ipi and nivo. In this current study, we did it at cycle 2, which is week 6, and what happened is about a third of patients in both pancreas and colon weren't able to get to the radiation part of it, which is really where we think the activity is happening. And if you lose that many patients prior to radiation, then we aren't affording those patients the opportunity to benefit. So the next study, we're going to keep the exact same dosing schedule of radiation, but move it up and see if we can at least maintain the activity. And if we can, then that leads the door towards more, I think, sophisticated radiation specific questions too. But right now, this is just a kind of early signals of efficacy. So one thing we did experience was some toxicity. We did have a grade 5 event, 1 in each cohort, but otherwise most of the toxicity was manageable. And so as we learn to use these drugs, we'll become more adept at managing the toxicity. But I think what we did have a good amount of, again, grade 3, 4 tox besides the 5, but most of those toxicities, again, were mild and manageable. For example, in the colon, we saw some, lymphopenia, which again we would expect even with radiation. And so, yes, it did meet grade criteria, but nothing that was significant. I think colitis was the one that we had to manage the most, but with the use of infliximab, we were able to manage the colitis. The other, I guess, notable thing I wanted to just comment on in terms of the efficacy was more than the responses, what we saw was durability, as what you see with immunotherapy. And so in the colon cohort, one of the partial responses patients is now coming up on 400 days plus of treatment. And so, in these cancers where your PFS and OS is very short, if you're getting the responses are long-lasting for those patients. So, more than fixating on the actual response rate numbers, I think when you look at the swimmer's plots that really illustrate how long the duration of the disease control was, I think that is also telling.